Hello and welcome back to another JOP podcast. This is Dr. Bob Miller from the JOP editorial board. Well, we hope you survived another ASCO annual meeting with 33,000 of your closest of friends. For today's podcast, we're going to take a look at a special series which was in a supplement to the May JOP issue entitled Payer-Provider Relationships in Oncology. Now, this is actually the second podcast in a row where we're going to be talking about a care delivery and reimbursement model called the patient-centered medical home. And I think this is something that is probably still fairly unfamiliar to most oncologists. My guest, Dr. John Sprandio, is an oncologist who is actually quite an expert on this topic. Dr. Sprandio is the lead physician of Consultants in Medical Oncology and Hematology, or CMOH, which is his medical practice outside of Philadelphia, and Oncology Management Services, which is his consulting firm. CMOH is the only medical oncology practice in the country that has been recognized by the NCQA as a patient-centered medical home. Welcome, John.
Thank you, Bob.
So talk a little bit first about the background. You mentioned the Medicare Modernization Act of 2003 as sort of setting into motion some fundamental changes in chemo reimbursement, certainly something that had profound effects on many U.S. oncologists. What do some of the recent data from COA show about the changes we're seeing in the site of cancer care delivery?
Well, Bob, as you know, there's been a significant shift of community-based independent practices towards the institutionally based model of delivering cancer care. Prior to this shift that we've really witnessed since 2008, the majority of patients were treated in the community-based setting. Perhaps 85% of all cancer patients were treated in that independent practice setting. Mm-hmm. Since 2008, there's been a significant shift, with that shift accelerating in 2010 and 11 towards a institutionally based model. The issue with that, Bob, is that oftentimes with that shift comes significant changes in the cost of care delivery.
So you suggest in your article that community-based physicians perhaps have not really been leading the response to these economic challenges, that third parties are perhaps doing things that we should be doing. What are some of the limitations that you see in the third-party pathway programs and some of the migration of care to these hospital and other institutional-based settings?
Well, the chemotherapy pathway programs, should be embraced in terms of their ability to standardize care and really provide some framework for quality metrics regarding the actual choice of chemotherapy agents and the execution of chemotherapy delivery. And they have had some positive effects on partially addressing these quality of care and some cost issues. But they really do provide a limited advancement in the value proposition from a patient service and disease management and even a long-term payer perspective. So I think that the pathways are helpful. Guidelines are also helpful in terms of standardizing a therapy within a practice. But the potential benefit in terms of controlling costs and keeping cancer care accessible to a broader number of patients, it really doesn't meet some of the additional need right at this point for controlling costs and standardizing care. It's still built around the pathway system programs are still built around. They're centered around a modified buy and bill drug reimbursement model, mm-hmm. and the patient-centered value proposition that we're proposing is actually absent from these models. In addition, the amount of savings in terms of the total cost of cancer care is somewhere in the order of 3% of the total cost of cancer care for a pathway program that's well adhered to. Now, there are additional potential savings in terms of decreased admissions and so on, but that's not the major focus of those programs. Regarding the institutional settings, as I mentioned, there's been a pretty dramatic shift in the site of care delivery, and it's basically the migration of independent practices towards the economic shelter that institutional programs can provide. And oftentimes, what we've seen in the last 2 or 3 years is with that shift, it becomes sometimes a substantial increase in the cost of care without any immediate or clearly demonstrable enhancement of quality. And when that happens in the delivery of medical care and oncology care specifically, is when you increase costs without increasing quality substantially, you diminish value. So, I think that we're seeing a period of rising cost for the actual delivery of care with this migration.
So tell me a little bit about your experience in your practice in setting up this patient-centered medical home. So you said in your article that you were formally recognized by NCQA, I think it was 2010, but I gather this was probably a very involved process that started long before that. Just give us a background of why you did this and what kind of steps you took to implement it.
Well, Bob, it became, first of all, we're in a very competitive marketplace in southeastern Pennsylvania regarding cancer care. We compete with 3 NCI designated comprehensive cancer centers that are institutionally based. And it's a pretty competitive environment. So we were always interested in differentiating our services and our practice. And we really paid attention to a lot of the additional critiques from the IOM regarding management of palliative symptoms and palliative care in general, how we deal with the survivorship phase of care, and also how we value cancer care in an era of increasing cost that outpace the increasing cost of medical care in general. So we went on a mission in 2003. It was coincident with the passage of the Medicare Modernization Act. But we went on a mission to really streamline and standardize our processes and our practice. So it called for a re-engineering of our process of care. We tried to minimize clinically irrelevant physician activity. We wanted to refocus with the patient in the center part of the equation. And we wanted to fix accountability at the patient-physician locus for all of our physicians in our practice. And we knew that there were major deficits regarding communication and coordination of care in cancer care in general, regardless of whether it was a community-based setting or an academic setting.
Sure.
So we did this, and we turned around in 2007 or 2008. And realized that we met the NCQA criteria for Level 3 patient-centered medical home recognition. So we actually applied, and they recognized us in April of 10.
So it sounds like you had sort of put the process in place before formally realizing this would qualify as the designated NCQA standard. It sounds like you sort of realized that after the fact.
We did, but Bob, if you look at it, it's not really a mystery because the NCQA, in terms of constructing their patient-centered medical home model, was paying attention and addressing the same issues that we were addressing, not in oncology care specifically, but in medical care in general. The fragmentation and the deficiencies in the U.S. healthcare system are pretty obvious, and the ways of approaching them. In terms of the fundamental way the care is delivered, is actually, in retrospect, pretty predictable.
So, what kind of results have you seen?
We've seen significant change in resource utilization within our practice, really in 3 major components. We've been able to significantly reduce ER utilization in our chemotherapy patients. We've had a reduction of approximately 68% in ER referrals per chemo patient per year since 2006. And it's been a steady decline that really hasn't plateaued. We've had a 10% reduction in ER utilization from 2010 through 2011. And it hasn't really plateaued. When you control ER utilization by enhancing access and increasing patient engagement, all those principles, some of the principles regarding the NCQA recognition process, you control admissions, unnecessary admissions. Our patients are complicated, as you know, and the physicians, the medical oncologists who are caring for these complicated patients, can best advise, first of all, whether an ER visit's necessary, And if you avoid an ER visit, you avoid a nervous ER doc from admitting the patient unnecessarily. So we saw a significant reduction in admissions. Since 2007, we've seen a 51% reduction in our rates of admission per chemotherapy patient per year. And that hasn't plateaued either. From 2010 through 2011, we dropped another 12%. That's partially because of the way that we review our data and our process. We can focus on different things. So, for example, the reduction in ER utilization and admissions in 2011 came a little bit more from reducing those services or controlling those services in the last 30 days of life. As you review data internally and you really embrace the idea of a process of continuous improvement, you really you find opportunities that are maybe unique to your practice or maybe unique or not so unique among all oncology practices. So we've had those kind of results. We've also had, since 2009, we've had a 34% increase in length of stay in hospice as well. And, those three areas are significant in terms of resource utilization. We've also been able to show decreased use of chemotherapy in the last 30 days of life in the past 24 months as well within our practice. So it's basically the model is really centered around something that's already out there, the template that the NCQA has provided, and the results and the continuous improvement in the results is really based on a rapid learning system with feedback for individual physicians as well as the practice in general.
That's very interesting. I think the first reaction most people would have is that obviously the payers have to buy into this. So I was just wondering, is this something that you approach the payers one by one, or did they kind of hear that you guys were doing this and came to you? Can you speak a little bit about your relationship with the payers and their buy-in?
Well, I can tell you that reforming the way that we delivered cancer care within our practice was a lot easier than executing payment reform. And there are several barriers that are completely reasonable and well understood by me. We've had a lot of interest from payers, from national payers and local payers, and we've had a lot of discussions. We don't have a contractual platform built around this model at this point in time that would encourage other practices to undertake what we undertook. Now, the reason for that, the barrier for the practices is, number one, there's some technology barriers for some practices, or a lot of practices. And number two is, when you really, really get good at taking care of patients, and you keep them out of the ER, you keep them out of the hospital, and you administer less chemotherapy. And we actually have documented that we have had less frequent office visits for our patients who are receiving chemotherapy because of the standardization of the visit and the completeness of the process. You hurt yourself economically. So there's no reason that any practice should really do this unless there's some type of economic arrangement to support the transformation and then to support the practice so that we can continue to function and continue to answer the call of improving quality and improving value. We're close in terms of discussions with a national payer and local payer regarding a platform, a payment platform that could support this. It's been a long process. We do have you heard me speak before, but we do have a small contract, meaning that with a small number of patients in our practice, with a Medicaid HMO that clearly understands what we've done, and has supported our efforts for their patient population. The challenge, Bob, for us is to expand and verify this model. The results that I mentioned are from one practice, our practice. And even though we've extended this model to a similar size practice, independent practice in Philadelphia, The burden is really on us to really prove the validity, and even to further prove the reproducibility. So we're really on our goals for 2011 are to really expand and verify this model. We're planning to develop a clinically integrated network of independent practices in southeastern Pennsylvania, and further test this model in a rigorous fashion with an academic partner. And we've started doing practice assessments and gap analysis for those practices that are interested in participating. We also have worked fairly extensively with the NCQA, ASCO, and COA in terms of developing or encouraging the development of a unified principle and unified model of the oncology patient-centered medical home. This is a multi-stakeholder change, and COA has actually led the way in developing a steering committee. I do serve on the steering committee, but it's a multi-stakeholder, 18-member steering committee that is reviewing and making some significant suggestions regarding quality and outcome measurements. They've done some work regarding patient satisfaction and so on. The NCQA is now very much interested in looking at this model, and basically they're interested in focusing on oncology to develop criteria that will be national criteria. So there's some standardization around this concept and model. The importance of the NCQA's involvement as the recognizing entity can't be overstated, I don't think, and because it provides a uniform model that payers can respond to. Then I think that's extremely important in terms of the timing of the applicability and acceptance of this model. We're entering an interesting phase of this effort. And we're very excited about it, and we're very excited to be working so closely with the NCQA and ASCO and COA on this effort.
What other oncologists think? I mean, people in your local community and other practices you've come in contact with. I'm guessing there's a little bit of bewilderment at first about what this is all about.
There is, Bob. But once we and this is not kind of a concept that can be shared and completely grasped with a 30-minute discussion or presentation. Most folks that have been to more than one or two of my presentations comment that they continue to learn with each presentation, because there are a lot of aspects of care that we really addressed and tried to rectify. But the response uniformly is, gee, I would love to practice like this. Or, gee, I think in some ways we do practice like this. And so the result has been very positive, because it's clear that the type of care that can be delivered in this model is the type of care that every single oncologist would want for themselves or their families if they required this type of care.
Sure.
It's very much based on access, increased access for the patient, engagement of the patient and their families, really a whole person approach to their issues, and really the acceptance of the responsibility for all the oncologic needs of our patients. So conceptually the acceptance is high. Practically, it's a scary proposition to invest further in your practice, disrupt your processes of care to some degree. Maybe it's not going to be a big disruption for most practices, but to some degree, and then potentially harm yourself economically, because we operate in a fee-for-service world, and we're providing care that does not match that type of contract.
What would you say to a practice that said to you, okay, I want to try this. What should my first step be? Should I go to a payer, or should I just try this myself and see how it works? How do you advise people? I guess a difference by market, but what kind of advice would you give to a practice wanting to get on board with this model?
Well, Bob, it really does depend on the market. What has to happen is you need to have a willing payer, at least one willing payer in the market that understands this. And there are several national payers now that do understand this. I mean, it's taken a little while, but they do understand it. So you need a willing payer, and then you need a practice with an internal champion who understands the model, who understands the goals, and sees the potential long-term value for not just community-based oncology, but for any cancer program. But for community-based oncology in particular, because right now community-based oncology is looking for various models that provide some economic predictability or provide a sustainable business model for their practices if they're going to remain independent. So it requires a willing payer, and it requires a practice that embraces the concept and sees the value. The next steps after that are to do a practice assessment and oncology medical home gap analysis, which we actually have been doing, and then engage payers during the transformation process.
So I got to say, you guys sound very brave to have sort of leapt into this. Being the first at anything is pretty challenging when you're facing the economic pressures practices are facing. So my hat's off to you guys for taking the first step.
Well, it's not a question of bravery. It's a question initially of seeing the deficits in the way the care was delivered, acknowledging that, correcting those, and then recognizing the fact that we are in the era of healthcare reform, regardless of what the Supreme Court decides later this month. In the era of increased data collection, more reliable data collection, the transparency of data collection, the increased accountability that comes with that, we need to have, all oncologists need to have a model of care delivery that really allows us to become more responsible and able to achieve the goals of better cancer care, better health for our patients at a lower cost. We all recognize that there's significant waste in medical care delivery in this country. We're well aware of the potential areas of wasted resources in cancer care specifically. This model that's really based on the NCQA, patient-centered medical home criteria, provides a care coordination and delivery model that facilitates physician accountability, encourages clinical integration between like-minded oncology practices. It enhances coordination and communication with primary care, patient-centered medical home practices, and it presents a new value proposition to payers, all the while that it focuses on patient need and evidence-based care. So it's a model that's pretty broad and addresses a lot of the components and areas of fragmentation and deficits that are pretty common in cancer care delivery.
Dr. Sprandio, thanks for taking the time to talk with me today about this very interesting work.
Thanks, Bob.
And thanks again for listening to our podcast and for your interest in the JOP. Be sure to take a look at all of the other interesting content in the May issue and this special supplement. Please visit our iTunes page to leave a comment about these podcasts or email us at jopeditorsdesk@asco.org. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.